I have your discussion D for the night. We are discussing care for older adults must be grounded in a rich, multi-dimensional understanding of human dignity. Okay? Especially as populations age and more people live with frailty or major neurocognitive disorders. It argues that dignity is not vague, not a vague slogan. But a set of concrete ethical commitments that shape how clinicians, caregivers, and institutions should act. By distinguishing different kinds of dignity and showing how each is threatened or upheld in geriatric care, the authors insist that ethical care is inseparable from relational presence, respect for identity, and protection of instinct. Worth. For distinct sense distinct sense of dignity, the paper uses human dignity and intrinsic non-negotiable worth that belongs to every person simply by being human. It does not diminish with dementia, disability, or dependence. This is the moral baseline that anchors all other forms of respect. Attributed dignities, socially granted roles, titles of honor, e.g., presidents, laureates. These can be lost and should not determine the quality of care. Though in practice, they sometimes distort access or expectations. Dignities of excellence, forms of worth tied to achievement, moral courage, and intellectual brilliance, artistic mastery, authentic accomplishments. These can fade with illness or age, and the article warns that overvaluing them can make older adults appear less worthy, then capacities decline. Then when capacities are less worth when capacities decline. Dignity of identity. The most fragile and clinically relevant from a person's sense of self, continuity, continuity, autonomy, and social belonging. This can be harmed by humiliation, neglect, depersonalization, routines, or the losses of illness. Protecting this dignity requires attention to history, relationships, preferences, and the small rituals that make someone them. How those concepts change what good care looks like. Care versus cure. The article emphasizes that geriatrics often requires shifting from aggressive biomedical intervention to relationship-centered care that prioritizes comfort, meaning, and the preservation of identity. This is especially true in dementia, where cure is impossible, but dignity can still be fiercely protected. Comprehensive assessment. The comprehensive geriatric assessment, or CGA, becomes a practical expression of dignity. It evaluates medical, functional, psychological, social, and environmental domains to understand the whole person and tailor care accordingly. It is a tool for seeing the person rather than the disease. Solicitude and presence. The authors draw on rigorous rescue to argue that suffering disrupts speech, action, and narrative identity. What restores dignity is not technically or technology or efficiency, but human presence, friendship, and attentive companionship. Forms of care that help a person regain agency and self-esteem even when capacities are diminished. Ethical and social risks. The article warns about uh, dementophobia and ageism. The paper identifies a growing culture pattern and an intersection of ageism, ableism, and mental health stigma that devalues older adults with dementia. This can justify neglect, harmful tragedy decisions, or dismissive attitudes that erode the dignity and identity. Institutional dilution of responsibility. In large systems, responsibility can become fragmented across layers of staff, protocols, and legal requirements. When no one feels personally responsible, care devolves into tasks completion rather than moral attention and dignity. It's easily lost. Is easily lost. Over reliance on technology. The authors caution that technological solutions, monitoring devices, automated systems, even care bots cannot replace the relational goods that sustain dignity technology may support. Care, but it cannot substitute for human presence, empathy, or recognition. Practical implications for clinicians, caregivers, and policy. Prioritize relationships. Train staff to notice personal history, small joys, nonverbal communication, and the emotional texture of daily life. These are the building blocks of the dignity of identity. Use multi-domain assessment. Let CGA findings guide individualized care plans that protect autonomy, safety, and social connection rather than defaulting to one size fits all routines. Embedded moral responsibility. Reduce bureaucratic layers that diffuse accountability, encourage community continuity of caregivers, reflective practice, and practical wisdom over rigid rule following. Design dignity preserving environments. Create spaces that protect privacy, support meaningful activity, and allow older adults to both give and receive care. Dignity is sustained not only by what caregivers do, but by the environments they shape. Respond to suffering with presence. Recognize that suffering disrupts speech, action, and narrative. Identity. Respond with companionship, patience, and emotional availability that help restore a sense of self. One line takeaway: protect both intrinsic human dignity and the dignity of identity by centering relationship-based, person-focused care rather than treating frailty as merely a biomedical problem. Okay, guys, that's your D for the night. I'll be back on tomorrow with shows. For now, Gator Wellness. Have a good night, folks.